I would like to introduce Dr. Matthew Copeland to you. I'll first introduce myself. I'm Prinsy Kumar from Infectious Diseases. Dr. Copeland graduated from West Virginia School of Osteopathic Medicine in 2015. We then had the privilege of having him join us at Georgetown for both his residency in internal medicine and his fellowship in infectious diseases. During his postgraduate training, he also graduated from the Global Health Program, spending clinical time in Thailand studying the management of tuberculosis, dengue fever, and rabies infection. While during his fellowship, he got the Paul Wilner Award for excellence in teaching residents, both at the end of his first year as a fellow and at the end of second year. And he's truly one of our most beloved faculty for both the residents and for many of the attendings. As part of he joined our faculty as soon as he finished his fellowship, and he's currently an assistant professor of medicine. Along with all of his responsibilities, he's currently the director of our outpatient parenteral antibiotic therapy program. We call it the OPAT. It's a very important part of our program because it manages home infusion of intravenous antibiotics for very complicated infections. And so he's our medical director for that. His special areas of interest are also the management of mycobacterial infections and other granulomatous infections, as well as tropical medicine and medical education. He will speak to us about cracking the shell of tuberculosis and other granulomatous infections. Thank you, Dr. Copeland. Let me turn it over to you now.
Thank you, Dr. Kumar. It was very kind of you. And so that's correct. I'm going to talk today about tuberculosis and other granulomatous infections and how granulomas that form during those infections change the way that we treat and the way that those infections present themselves. So first, these are my learning objectives. My goal for this talk is for you to understand the basic pathophysiology of granuloma formation and how it affects how a disease comes about. We'll contrast the characteristics of different granulomatous infections. And at the end, I'm going to give you sort of my approach to a patient with a suspected granulomatous infection, patent pending. I have no disclosures or conflicts of interest. So that the talk is split into actually two different parts, and those two parts are going to go over 4 topics here. First, I'm going to talk about the prototypic granuloma that's formed during a tuberculosis infection. Then we'll go over new information that challenges the idea that the granuloma is just a wall there to contain whatever's inside of it. So the first half of the discussion is going to be very heavy on tuberculosis, but then the second half will go into other infections that cause granulomas. And then lastly, we'll devise an approach to use in those patients and then go over 3 cases where we use that approach. I have 2 warnings before we start. The first warning is that there's a lot of immunology in the initial portion of this discussion. It's kind of hard to talk about granulomas without talking about immunology. And so I won't be offended if you zone out, and I won't even know if you do, but I'm going to wake you up when we get into the second part and get into more clinically relevant things. The second warning that I have is that I'm not an immunologist, so my deep understanding beyond the papers that I present to you is somewhat limited, but if you have a question at the end that I cannot answer, I promise that I will get back to you. Okay, so let's go ahead and start, and let's start with a case. This is a patient who's sent to your clinic for an evaluation. This is a 49-year-old man with multiple sclerosis who's on an immunomodulatory therapy, and he was previously treated for colorectal cancer with a primary resection about 15 years ago. And he came in with 5 months of fatigue and an enlarging left-sided, around 3-centimeter lung mass with some associated ipsilateral hilar lymphadenopathy. And he has a heavy smoking history, and he works in a sheet metal plant. And the first concern that his physicians had at that time was a malignancy. So he underwent a couple biopsies that were non-diagnostic and eventually a resection. In that resection, the pathology returned with necrotizing granulomatous inflammation. So then they're sent to us to sort of help figure out what is causing that. And depending on who the surgeon or what the surgeon suspects is the cause of the inflammation, kind of directs where the patient goes to. But usually it's a mixture of ID, pulmonology, rheumatology, or a combination of the above. And so my hope is that by the end of this presentation, you will have some idea of how these granulomas come to be in infection, especially the most common cause of granuloma formation in the world, which is tuberculosis, and how to effectively approach this kind of patient. And to give you some type of closure, this patient's lung culture from tissue eventually grew MAC. And as he had a full resection of his lesion, there was no cancer, just MAC. We treat him with a relatively short course of antibiotics, which in the case of MAC was around 4 months. And he has a durable cure now about 4 years out. Okay, so to think about a granuloma in the simplest terms, it's a focal aggregate of cells, immune cells that are responding to some type of inflammatory stimulus. And that can be a bacteria, it can be a fungus, it can be a foreign object, an autoantigen, or sometimes it's something that's not readily apparent to us. But the most important and most common cause of granuloma formation in the world, not that I'm biased, is tuberculosis. So oversimplifying this a bit, the quintessential initial event in the formation of a granuloma in TB is the first macrophage ingesting the first tuberculosis bacilli, and I've highlighted this on the left for you. Invariably, this macrophage is killed by TB. And then more macrophages will arrive to the scene. They'll just keep throwing themselves at TB, and they will just keep getting killed by TB. Some dendritic cells and some neutrophils will come in as well. And this non-directed, non-specific response by macrophages creates what we call the innate granuloma. And TB continues to divide inside of these dead macrophages until about 2 to 3 weeks later, where the adaptive immune response can kick in. But until that happens, around 90% of the time, the innate granuloma is unsuccessful in preventing a TB infection. Maybe around 10% of the world is able to resist this initial infection. They're called resistors, which is a very original term. But eventually, over the course of about a month, maybe a little bit longer, TB-specific T cells will start to direct the granuloma, and they'll do that in a few different ways that we'll talk about. One of the important mechanisms is through interferon gamma release. But these T cells are important in creating a more mature form of the granuloma, which we call the immune granuloma. And at this point, once you have an immune granuloma, that granuloma can go one of 3 ways, which depends on the immune response, how much the immune system is there, which we call the tissue hypersensitivity, and the mycobacterial load, or how much TB is there. So the main goal of the CD4 response is to activate macrophages to their ultimate potential. And one of the important pathways to which that happens is through the release of interferon gamma. And that sort of backs up why we're so interested in interferon gamma when we're looking at the presence of TB. I think of macrophages as sort of like little lemmings. They're weak on their own, and then they'll just keep going in one direction until someone comes by and directs them. And when they're directed, then they can be successful. So when tissue hypersensitivity is high, meaning that the immune system is willing and it's able, and the antigen load is high, meaning that you have a lot of TB, the CD4 cells are going to do what they can, but there's still a bit of a struggle in getting the immune system to act right. And so this eventually produces an exudative type picture during which tissue necrosis can happen. The necrosis from TB is incomplete. It creates sort of this semi-solid structure, and that looks like cheese, and so that's where the term caseating necrosis comes from. And caseating necrosis will kill mycobacteria, but it also causes a lot of tissue destruction. In the case of a pulmonary infection, the mycobacteria can escape. They escape into the bronchial tree, and then that's sort of what leads to cavity formation. But necrosis doesn't always have to overcome the site, and the balance can shift in the favor of the patient. So this is a slide here of a typical granuloma that you would see in a tuberculosis infection. On the right, marked by the asterisk, is an area of central necrosis, caseating necrosis. The CD4 cells are going to release interferon gamma, which is going to activate macrophages that are already surrounding the area. And some of those macrophages will become highly active and form what's called epithelioid cells. And they're marked here by the arrowhead. And these cells are tightly linked. You can kind of think of them like a zipper. They interlock together and create a tight seal, and the goal is to prevent whatever's inside of the granuloma from escaping. Some other stimulated macrophages will fuse together, and they'll push their nuclei peripherally, and they'll create what we call a multinucleated giant cell, which you see here on the left, and that's marked by the arrowhead. The true purpose of these cells is not really well known, and if you look in the middle in the cytoplasm, you'll find sometimes a lot of lipids. If they really accumulate, that's how you end up with the term foamy macrophages. You'll find crystals sometimes, but you actually won't find a lot of bacteria. So it seems like they're not really there for phagocytosis. They're there for some other reason, but that other reason we don't quite understand. It can be hard sometimes to make these things out on an actual slide, so I have a nice cartoon for you here. You see the necrotic center here with a lot of TB and dead macrophages, which is kind of that orange thing that's falling apart. You see the zippered together epithelioid macrophages making a tight barrier. You see these large cells with nuclei on the peripherally. Those are your multinucleated giant cells. And then surrounding the granuloma is a circle or a cuff of lymphocytes. And that's where the T cells are going to be, and they're sort of going to be helping to direct what's going on. So I call this the iffy granuloma because it can lead to success or it can lead to eventual failure. So if this granuloma remains successful long enough, you may or may not have fibroblasts that start to encase it and scar it. 90 to 95% of the time, the granuloma is successful in containing TB. And so these sites are sometimes visible on chest imaging as a calcified nodule. And you may be surprised or maybe horrified to hear that up to 30% of the world's population has been infected with TB. So it's pretty common to find these things. But calcified nodules are not specific to TB in themselves. So just because you see one, don't assume that they're all caused by tuberculosis. Often, these things are incidental findings, but in the context of TB, they're generally indicative of a prior infection. But don't be fooled, but just because you see a calcified nodule doesn't mean that all the TB is gone. In fact, many patients will have a latent or contained infection that can reactivate if the immune system becomes disrupted in some way. And that disruption can happen through intense immunosuppression like a transplant or HIV infection, or it can be something that's less drastic like type 2 diabetes or hemodialysis. Those are all significant risk factors for losing containment of TB. So this CT is from a patient of mine who had pleural TB. And you can see his pleural effusion there on the left side. And he had absolutely no parenchymal involvement. And the only clue that he had been previously infected with TB was this right-sided calcified lung nodule. Prior successful immune response to TB and even prior treatment for TB doesn't give you any durable immunity. In fact, a prior history of TB should raise your suspicion further that TB is the cause of your patient's current presentation. So just because you see a calcified nodule and you think to yourself, oh, this is probably old TB, it doesn't mean that TB is not causing whatever's going on with the patient at that time. Now, what happens if a granuloma fails? In patients who are unable to produce an organized response, poorly formed or no granulomas can develop. And so these are slides from what we call non-reactive tuberculosis. On the left is a slide of splenic tissue stained with an acid-fast stain. So everything that's highlighting there, those rods and those dark dots, that's all TB. And so you don't see the architecture and the structure that you would expect in a granulomatous infection. There's maybe some non-specific inflammation in there, but there's definitely no giant cells. There's no lymphocytic cuffing. There's not really a good response there by the immune system. And on the right side is lung tissue. This is stained with an H&E stain, so you won't see tuberculosis, but you do see necrosis in the top right corner. And maybe there's a hint of some lymphocytic cuffing there, but again, it's not really that organized response that you'd expect to see. So this is the least successful response to tuberculosis by the immune system. And without treatment, it's invariably fatal. So let's recap a few things I talked about. If you remember nothing from what I just said, try to remember these three things. One is that granulomas are coordinated immune responses to a persistent inflammatory stimulus. They're not specific, but they are supposed to be coordinated. Successful containment of infection requires macrophage activation, but successful containment does not indicate eradication. And immunodeficient patients with florid tuberculosis may produce poorly formed or no granulomas at all. In fact, they may just have a varying degree of nonspecific inflammation. And so in other terms, that means that just because you don't see granulomas doesn't mean that TB is not there, especially in an immunocompromised or deficient patient. Okay, let's move into the next part of the talk here. It's often taught that granulomas are macrophages that are forming a wall around tuberculosis that the immune system is containing or it's trapping it. And we thought that the granuloma was purely a host defense structure because we have data that shows that at about 2 to 3 weeks after initial infection with TB, the mycobacterial load decreases. And that's around the time where you expect the adaptive immune response to start kicking in. So we thought that the innate granuloma was more of just a precursor and not really that important. But relatively new data tells us that the granuloma is not really a prison for TB. In fact, TB can actually thrive inside of the granuloma. So it's more like it's hanging out on its own secluded beach. And using data from zebrafish embryos with a Mycobacterium marinum model, and that's a bacteria that does cause infections in humans, but in TB it causes a infection, or in fish it causes an infection very similar to tuberculosis. We now believe that TB uses the granuloma to its advantage. It rapidly divides inside of the macrophages that are attacking it, and it actually calls in more macrophages to the granuloma. And it does this with a signaling pathway called Esat6, and that's coded on the Rd1 gene. And I think the Rd1 gene is going to be important in the future in managing tuberculosis, so I want to kind of explain to you how we think it works. So not only is TB chilling on the beach, it's also sipping its own cocktails of Esat6. It's quite happy. So the specific TB gene that I want you to remember is called Rd1. That stands for region of deletion 1. And it codes for this signaling pathway called Esat6, which creates this molecule called Esat6, or early secretory antigenic target 6. And some of you may recognize Esat6 as one of the TB antigens we use in the quantiferon interferon gamma release assay, along with another one called CFP10, which is also co-secreted with Esat6. So hence, Esat6 is very immunogenic. What I'm going to say next is going to seem a bit contradictory, but if you think of TB as more of a clever organism as opposed to an inanimate rod, it gives you the right frame of mind to be in. So Esat6 is like a chemotaxin. It attracts macrophages to the innate granuloma that's formed in an initial TB infection. So why would TB want to attract the immune system? Well, it turns out that as morbid as it sounds, TB uses dead macrophages to divide. So more dead macrophages equals more TB. And Esat6 increases the virulence of TB in killing the innate macrophage. And it does that probably by affecting the macrophage's ability to complete phagocytosis. And then it attracts more macrophages to the granuloma. And those macrophages then ingest the dead macrophages that are already there. Those macrophages die, and it just becomes a vicious circle. And TB uses that vicious circle to proliferate itself until the adaptive immune response can kick in and get the macrophages to stop doing these weird things. Tuberculosis also knows that it has that time limit until the immune system kicks in. So what it will do is Esat6 will increase the speed of the macrophages that are coming to the granuloma, and it will change their morphology so it's easier for them to get through the tissue. So TB, through the secretion of Esat6, favors the innate granuloma. As a side note, Esat6 also affects epithelial cells, and it makes them release these types of metalloproteinases that allow macrophages to move through the area, and also attracts more macrophages itself. In zebrafish models, again, using Rd1 deficient fish TB, the lack of Esat6 leads to delayed granuloma formation and decreased bacterial proliferation. So that sounds weird, but that's what happens. So TB without Esat6 is very attenuated. Okay, so we know that the formation of an innate granuloma is directed both by the immune system and also by tuberculosis, but what about a more mature granuloma? The adaptive immune response, that's when the T cells come in, is important in the defense against TB. We know that because patients with T cell deficiency, such as HIV or solid organ transplant, they're at a much higher risk for developing tuberculosis infection. But TB has an effect on that part of the immune system as well. It's going to delay the recruitment of T cells by delaying antigen presentation, and it also upregulates the production of T regulatory cells. And we think that maybe by the time that the T cells are able to figure out what's going on, the proliferation of TB is just very high at that point, higher than the rate of sterilization. We also think that TB is going to hide its antigens, so it's not detected as well, and it also sequesters itself in cells that are poorly presenting. So it's rapidly dividing, and it's also hiding itself from being detected. So this explains why after years of having fully formed granulomas, you can still find tuberculosis in it. And this also explains why having active granulomas in the body during an active TB infection, any superinfecting TB, and that's TB that you inhale while you already have tuberculosis, those bacteria are going to go to the granulomas. You would think that they go to an area where the immune system is not already at, but they're going to go right to the granulomas. And so it seems like that is an area that, that is beneficial to tuberculosis. So despite having full maturity of a granuloma, TB remains present. I'm not going to go into the mechanisms of how TB reactivates, but you can see based on what I'm saying that sometimes it's not necessarily reactivation of TB, it's more of a loss of containment, escape, or release. And just as TB uses dead macrophages to proliferate, it uses living macrophages to disseminate. It's basically going to hop a ride from wherever the initial infection is to lymph nodes or to some other distant area of infection. In a healthy patient, the risk of TB escaping from a granuloma or reactivating is around 0.1% a year, and that's cumulative. But if there is T cell deficiency, that rate goes up to 100%, especially in HIV patients and patients with solid organ transplant. So it's important to be able to identify these patients and treat them with antibiotics to eradicate any residual bacilli that are present. So the last thing we're going to talk about from an immunology standpoint is tumor necrosis factor alpha. And we've all heard from TV commercials that blocking TNF pathway increases your risk of developing tuberculosis. And you may think that that is because the TNF affects the formation of these granulomas, but that's not totally true. But let's set some ground rules first. I'm not going to totally blow your mind. TNF deficient humans are hypersusceptible to TB. That is without a doubt, and we see that clinically often. In patients with either induced or genetic TNF deficiency, the granulomas are poorly formed or they're non-existent. So think of the non-reactive TB that I showed you a few slides of earlier. As you can see in the slides here on the left, when TNF is present, the epithelioid cells that are surrounding that necrotic center are organized, and you can see a nice highlighted line of cell connections, and that's sort of behind the white arrow there. But in TNF deficiency, you don't see that nice organized line of connections. Instead, you see something that's disorganized and probably very leaky. And if you look at the amount of viable tuberculosis in a target organ with TNF active or with TNF deficiency, the amount is similar up until about the 2 to 3 week mark, and then TB just kind of takes off at that point, and that's because that's about the time where you'd expect the adaptive immune response to kick in. But if we go back to our zebrafish friends and we look at TNF signaling when it's knocked out, we knock out TNF in a fish embryo, and we look at granuloma formation, we actually see accelerated innate granulomas, and we see higher Rd1 expression by TB, which favors even more innate granulomas formed. But these granulomas that are made are highly unstable and they don't last very long. And the reason we think is that TNF deficiency probably more so affects the killing activity by macrophages and not really their ability to surround and make granulomas. And so in TNF deficiency, you are making those innate granulomas, and they're accelerated. They just don't last long, and they're much weaker than they usually are. So think of it as like a poorly made crumbling wall. And when that wall breaks, TB is able to escape extracellularly, and when that happens, it can be unstoppable. So Esat6 is a very important signaling molecule in TB infection, and there's interest in using it to develop vaccines, monoclonal antibodies, and using it to monitor how much TB is present in the body, and monitoring the treatment that you're using against TB. Aside from using Esat6 as one of the antigens in the quantiferon test, there's nothing else that's commercially available right now that uses it. But in the vein of vaccination, this is a study that's using an intranasal vaccine in mice against TB with an Esat6-based antigen. And these graphs demonstrate corresponding interferon gamma release in certain parts of a mouse about 6 weeks after vaccination. And you can see that there's high interferon gamma release in the blood, the spleen, and the draining cervical lymph nodes, but not really much in an inguinal lymph node, which is a distant site from where they vaccinated. And that suggests that mucosal vaccination against TB with Esat6 is going to produce a localized site at the primary infection, and that's actually ideal when you're aiming to prevent TB. Esat6 produces immune response, so what? Does it actually prevent TB from dividing? But if we look at 10 weeks after vaccination in mice, and we look at the mycobacterial loads, they're actually lower in the mice that were vaccinated, similar to vaccination with BCG. And furthermore, if you use an Esat6-based vaccine 8 months after BCG vaccination as sort of a booster, you get even more interferon gamma release, but it doesn't last long. It wanes over time. There's some human trials going on right now with Esat6-based vaccines, but they're in phase 2, as far as I know, and that's since looking at the 2020 pipeline from TB, so nothing available yet. Okay, let's recap again. Here's the salient points that I think are important to remember. Granulomas are important in the proliferation of tuberculosis, and TB enhances further granuloma growth. Esat6 is an important virulence factor in promoting TB, and it can potentially be exploited via therapeutics. And lastly, the adaptive immune response can contain TB, but commonly it cannot sterilize it. Okay, so this is the part where we get to the clinically relevant side, and this is what we're going to deal with ourselves. And if you fell asleep earlier, I forgive you, but please wake up now. I made a little bit of an overzealous statement when I said that tuberculosis is the prototypic cause of granulomas. Maybe the simplest cause is the foreign body granuloma, and this is a little bit easier to conceptualize. The body is walling off something that doesn't belong, and that can be talc, that can be thorns, hyaluronate, filler, a lot of other things and these things don't have minds of their own. They're just kind of stuck in there. And generally the immune system is able to contain it, and it's not as complicated as dealing with a living organism. And so this is a granuloma forming around a wood splinter between someone's toes. And this was, I think, a tennis player who was playing tennis without shoes on and stepped on something and got a splinter. And he had these skin lesions for months. So eventually they biopsied it and they found a piece of wood in there with a granuloma forming around it. And the cells may push the splinter out, or they may just wall it off forever. Aside from foreign body granulomas, we have varying classes of granulomas. The most familiar to us is probably the necrotizing versus the non-necrotizing granuloma. But there's a couple other different differentiations. Tuberculosis is not the only cause of necrotizing granulomatous inflammation, not by a long shot. And it's important not to confuse caseate necrosis with all necrosis. There's a lot of other important causes of necrotizing granulomas, and this list is overwhelming, so I've tried to make it a little more focused. But you can see it's very diverse. There's bacteria, there's fungi, there's a couple viruses, and there's also a couple parasites. But you see that mycobacteria and fungi make up a big portion of the list. And so they should always be on your mind. Aside from mycobacteria, don't forget important causes like histoplasmosis, especially in this area, coccidioides, especially if you're in the Southwest United States. Some of the things on this list we don't see in US-born patients, but are very important in other countries, like schistosomiasis, which is a very large cause, if not the #1 cause of both pulmonary and portal hypertension in the world. So these are important things, and you can also never ever forget about syphilis, because it will produce necrotizing granulomas. And so there's so many things that will do it, but like I said, the most important one and the most common one in the world is tuberculosis. And I don't want to anger any of my friends in pulmonology or rheumatology. This is a list of infectious causes, but there are many other important non-infectious causes of granulomas to consider, like, of course, sarcoid, GPA, rheumatoid arthritis, other vasculitides, drug-related injuries, foreign materials, and also certain malignancies as well. Maybe if we break down causes of granulomas by their site, it makes this a little easier to differentiate, and it turns out that's not really the case. It's still very broad. We're seeing a trend here that granuloma formation is not specific in itself for anything, and unless you have a confirmatory test like a culture or a PCR that is able to narrow down the cause, it's something where you're going to have to truly clinically correlate. But here's two things to always have on your mind when thinking about granulomatous infections. That's mycobacteria and histoplasmosis, especially in this area. Sometimes the way a granuloma looks or the patterns in the surrounding tissue can also give you clues as well. So on the left here, this is a donut granuloma with a thick fibrin ring, not really any necrosis. And this happens often in hepatic Coxiella or Q fever. And on the right, this is a microabscess. It's not really a granuloma, but it looks like one. It's granuloma-like, and we see this in Bartonellosis. This is also in the liver. And you have these palisading histiocytes sort of surrounding it. They're not epithelioid because they're not kind of zippering together, but instead they're stacking on top of each other. And you see internal necrosis, of course, and then you see a surrounding fibrin ring. And if you were to zoom out, it would be sort of like a stellate appearance. So sometimes the way a granuloma looks or the surrounding tissue is also a clue. Before we get into some cases and how to approach the patient with granulomatous infection, I want to talk a bit about how granulomas affect the clinical presentation of illness. And one common characteristic between major causes of granulomatous infections is clinical latency. And so this is defined as the presence of an infection without the signs and symptoms of an active illness. And only a few infections have a defined latent syndrome, and that's latent TB and latent syphilis. But if we look at the incubation periods of a few common granulomatous infections, we see that they're quite long, comparing to the more classically purulent infections like staph or strep. TB can present anytime from 2 to 3 weeks as from initial infection as a primary infection, or cause lifelong latency. Non-tuberculous mycobacteria can take months to years to present, depending on where the infection is. Histoplasmosis can present hyperacutely, but it can also develop lifelong latency along with coccidioidomycosis. And then lastly, syphilis, we know, can present with a primary chancre, secondary illness, all within the first 1 to 2 years. And then it can establish lifelong latency and pop up again 20 or 30 years later as tertiary disease. And if you look at other granulomatous infections, there's a common trend there. Along with clinical latency, the treatment of granulomatous infections tends to be long, typically in the orders of months, but not uncommonly in the order of years. And this is due to the slow dividing nature of a lot of these organisms, but it's also potentially due to the lack of antibiotic penetration into the granulomas. And so though these bacteria are genetically susceptible in vitro to antibiotics, sometimes they can become phenotypically resistant, especially when they're in an area that's resisting bacterial division. Syphilis down at the bottom, it's the exception. And it usually is it's special. You can cure syphilis that's been there for a year with a single dose of IM penicillin, or you can cure it that's been there for 20 years with 3 doses. I don't really have a reason for that difference, except to say that when you are able to use penicillin for anything, you should, because usually good things happen. One of the big things in the ID world these days is therapeutic drug monitoring, especially monitoring of drug levels that is not classic. So I'm not talking about vancomycin drug levels. I'm talking about levels of drugs like cefepime and azithromycin. And this is becoming more prevalent in the treatment of tuberculosis. The medications that we use now that make up RIPE therapy, the doses and the regimen has been the same for half a century. And they didn't go through the typical pharmacokinetic rigorous studies that we do now with new antibiotics. So we're doing that now. And what we're finding is that increasing the doses of certain antibiotics like rifampin or any other antibiotic in the rifampicin class, or using more microbiocidal antibiotics like high generation fluoroquinolones, moxifloxacin or levofloxacin, we can shorten the duration and improve the treatment of TB. When we think about treating a granuloma, we need to remember that the medication has to be well absorbed into the bloodstream, then it's got to get into the tissue, and then it's got to traverse the granuloma into a necrotic center, which is not a great place for an antibiotic to stay active. But then it's also got to make it into the bacteria and get to its target. So that's a very long way. And if we compare the tissue levels versus the lesion levels, and lesion here stands for granuloma, of various anti-tuberculosis antibiotics, in most cases, the amount compared with the amount in the blood is going to go down as you go into the tissue and then you go into the lesion. But for some reason, moxifloxacin actually accumulates in the lesion at a much higher level than the rest of the surrounding tissue. And recent data from an important phase 3 clinical trial on the treatment of tuberculosis suggests that if we use a higher doses of rifampicin and switch out ethambutol with moxifloxacin, it allows us to shorten the duration of treatment of TB from 6 months to 4 months. And I suspect that that probably has at least something to do with higher accumulation of these drugs in the granulomas. Okay, so let's approach that patient scenario that we had in the very beginning again. And so this is a patient who's presenting with a lung nodule where granulomatous inflammation is found. And depending on who you are and who the patient is, different things are going to be popping into your head. Is this tuberculosis? Is this MAC? Is this sarcoid? Is this some type of fungal infection? Or I don't know what this is. So here's what I recommend happens. First thing I would say is talk with a pathologist. Usually when you see granulomatous inflammation, it's going to reflex to other types of staining on the tissue. It should reflex to an acid-fast stain, like a Kinune stain or a Ziehl-Neelsen stain, or and a fungal stain like GMS. So those will probably be done, but talk with the pathologist and make sure that you need to do everything you can to rule out infection. Also talk to them about the surrounding architecture. If they know to consider Bartonellosis because your patient has a kitten, then they'll carefully look for those microabscesses in a stellate pattern, or they may use a different stain, like a silver stain, to see if they can highlight the bacteria. So if they know what's on your differential, then they'll be able to help you out and try to find that infection. Number two is make sure that there's culture performed. And if it hasn't been done yet, try to track down the sample and send it. Common scenario is a patient coming in for a biopsy because malignancy is very high on the differential. So really the sample is just sent for pathology. And then it comes back with granulomatous inflammation, and then we kind of have to backtrack. And that's a difficult spot to be in because you don't want to waste testing when you think it really is cancer. But when it comes back with this granulomatous inflammation, sometimes it's a mad dash to make sure that your sample hasn't been dropped in formalin or something. So the best that you can, make sure that there's culture sent, and that includes bacteria, AFB, and fungal culture. If you have a positive AFB stain and you don't have an AFB culture, that's a very frustrating situation to be in, and that often requires another sample, which may mean another biopsy, which may mean another procedure. So the best that you can, try to make sure that you have culture done. And that comes up to my next recommendation, which is try to hold fresh sample. It's important to get culture because that's how you're going to get your susceptibility testing. But there are some bacteria and other microorganisms that will not grow in culture, or sometimes are unsafe to grow in culture, like Coxiella or Bartonella, or Brucella. And you're going to need tests like PCR or other molecular tests. If the sample was dropped in formalin and it's not fresh, that's really going to affect the sensitivity of your test. So try to see if you can hold some fresh sample until you have a diagnosis. And the last, but probably most important thing is to use what you got from the patient interview in the exam to investigate the case and look for clues for other testing that you can send. And that may be in syphilis testing, that may be in histoplasma antigens. If you look at all the testing that's available for these infections that cause granulomatous disease, you're going to be overwhelmed. And there's so many different types of antibodies you can send out. And if you pick the wrong one, sometimes you'll end up with a false positive test. And so we really need to think about, do I even need to send that test first? So it comes down to some diagnostic stewardship. You know, if your patient has never been to the Southwest United States, then you probably don't need to send that Coxi antibody. But use your clues that you have. Necrotizing granulomatous inflammation in a patient from an area that's highly endemic to TB is TB until proven otherwise. So use that information. And then lastly, if you find nothing, if you did your best workup and you don't find anything, then consider non-infectious causes like sarcoid. So let's take a look at a few cases. These are real cases that I saw in the clinic or on the wards. So the stories are real, but the pictures are not, because they're better quality than the ones that I have. So this first one is a 57-year-old man, and he's coming to the clinic. He was referred from an outside facility with chronic cough, a left-sided 3-centimeter pulmonary nodule, and left-sided ipsilateral hilar lymphadenopathy. He lives in Maryland, and he loves to compost, but he has a history of colon cancer. It sounds like our prior patient, but it's not the same, I promise. He has a history of colon cancer, and so the concern was that he had recurrent malignancy. So he underwent a stereotactic biopsy, and that showed necrotizing granulomatous inflammation. And talking with his family, it turns out that during the pandemic, he took on this hobby of composting. He would go out once a day and just turn the compost for up to 30 minutes. I don't know if you're supposed to do that, but that's what he did. So he really loved doing it. So you can imagine that he's inhaling these plant particles, soil, and there's a lot of things that live in there. So if we go down our list of what to do with granulomatous inflammation, step one was talk to the pathologist and send other staining. So his AFB stain came back negative, but his GMS stain came back positive. And the stain and the organisms that were seen were intra and extracellular yeast, and they're morphologically consistent with histoplasmosis. So step two, which is send culture, step three, which was save tissue, both of those were skipped. But luckily we had this finding here, which essentially confirms histoplasmosis. I treated him with itraconazole, and he has a follow-up CT scan now about 4 months after treatment, where everything is totally resolved. His cough is much better. Case number two, this is a 61-year-old woman with a prior history of pulmonary sarcoidosis, which is in remission, NASH cirrhosis, and underwent a liver transplant in 2013. And she's coming in with a painless, enlarging left-sided cervical lymph node over about 2 to 3 months. She never traveled outside the country, and she didn't really have strong risk factors for prior tuberculosis exposure. This was hypermetabolic on PET, and so lymphoma or PTLD, post-transplant lymphoproliferative disorder, was considered, and she underwent biopsy first, which showed nonspecific inflammation, and eventually a resection of that lymph node, which returned with this. And this is ill-formed granulomatous inflammation. You can see that sort of at the bottom here, there's maybe a hint of some macrophages coming together and trying to make a multinucleated giant cell. There's maybe a hint of some lymphocytic cupping around the edge, but it's barely formed. And so this may fit sort of on the upper end of the non-reactive inflammation that I mentioned earlier. So step one, AFB stain and GMS stain were performed, and the AFB stain came back floridly positive, and there were acid-fast bacilli all over the place, but most of them were intracellular, which can sometimes be a bit of a hint. Step two, which is send the tissue for culture, was not initially done, but because step three was followed, which was hold fresh tissue, we were able to go in and send that tissue for acid-fast culture. And like I said, having a positive AFB stain without an acid-fast culture pending puts you in a very difficult spot. But luckily, we were able to get that done. And in about 14 days, this grew MAC. So this patient was eventually diagnosed with disseminated MAC, and that was based on other imaging and her blood test and her blood cultures being positive for MAC, and she's still being treated. But this is an example where, because of T-cell deficiency from her transplant medications, she didn't end up with those nicely formed granulomas, but doesn't mean you can't forget about an infection that usually creates granulomas. So here's the last case I want to talk about. This is a 61-year-old woman with schizophrenia, type 1 diabetes, rheumatoid arthritis. She's on methotrexate and tofacitinib for maybe about a year, and prior treated latent TB, who was admitted to our hospital with acute psychosis along with abdominal pain and persistent fever. And this abdominal pain had been going on for about 2 months. As part of her workup, she had a CT scan, and that showed partially necrotic retroperitoneal nodes in the aortocaval space posterior to the IVC, the largest one being about 2 centimeters. And so you can see that sort of to the right of her right kidney there, or medial to the right kidney, You see sort of a hypoattenuating area and then a dark center in the middle. That's the necrotic lymph node. And so lymphoma was considered based on the duration of symptoms, and she underwent a percutaneous biopsy, which came back with necrotizing granulomatous lymphadenitis. On step 1, we sent off an AFB stain and GMS stain. Those returned negative. We sent off bacterial AFB and fungal cultures. Those were pending. We asked for some extra studies on the tissue, like a TB NAT, which is a type of PCR to run. That came back negative. And then we used our information from discussion with the patient and with her family. And what we learned is that as a child, her father was treated for tuberculosis. And as she was a close family contact, she received 6 months of INH, which was the standard at that time. But what we found out from talking to another family member is that about 4 or 5 years after her father was treated for tuberculosis, her aunt developed tuberculosis. And we're not sure if the patient received INH treatment after that exposure. So it seems like she had repeated exposures to TB. And so that kept TB on our differential. And at 4 weeks, her AFB culture did actually grow tuberculosis. So this patient was diagnosed with a localized retroperitoneal lymphadenitis from TB with no signs of active disease anywhere else in her body. And so I want to say that every single one of these patients presented with an indolent illness that was initially thought to be a malignancy. And that was thought because of how it presented and the fact that the patients didn't actually appear to be septic. It's hard to conceptualize that someone can have an active infection for 2 or 3 months and not be in the hospital at that point. Remember that's how granulomatous infections present. So always important to keep that on your differential. So here's my final wrap-up. First thing is that granulomas can benefit the host, but they often can be exploited by the pathogen. Case in point here is that TB will mock us by using our own immune system against us. Granulomatous infection has a very diverse etiology, but you should always have mycobacteria and fungi on your differential. And then lastly, granulomatous inflammation is not specific, but it really means that something is going on, and it needs to be further evaluated, and that should include staining for microorganisms, culture for microorganisms, and performing adequate interview. So that's all I have. Thank you again, everybody. I very much enjoyed putting this presentation together and giving it, and I wouldn't be here today if it were not for this incomplete list of people that I have here. But thank you again. I was very excited to do this today.